Hello everyone, I'm Irene and I'm going to talk about my favourite subject, which is to dip or not to dip. I'm sure some of you have heard of this before. I think it's a bit slow.
Is it?
I just have to wait. That's it, patience. So, does everybody know what a urine dipstick looks like? Yeah? How many of you use a urine dipstick in your care homes or still using dipsticks? Oh, a lot not using dipsticks. That's brilliant. Urine dipsticks were used for a long time to diagnose urinary tract infections, and as we all know, we love to use them because they give us a quick diagnosis to see if someone has a urinary tract infection. What we're looking for is blood, leukocytes, protein, and leukocytes, and nitrates to see if someone has a urinary tract infection. However, NICE, National Institute of Clinical Excellence, have a quality standard that states that we should not be using urine dipsticks in over 65s. They've just recently updated all their literature around UTIs and have come out and said anybody over 65, we should not be using a urine dipstick. This is because it can vary and it doesn't always mean if a positive dipstick leads to someone have a urinary tract infection. What we should be looking for is clinical symptoms. Works. Has everybody seen our UTI checklist? The idea of the UTI checklist is for you to make the diagnosis of it, or not even a diagnosis of a UTI, but for you to think of the clinical symptoms to support your decision. So if your resident or the person you're looking after has 2 or more clinical symptoms, signs or symptoms, then that is more suggestive of a UTI than a urine dipstick. So if we think of the common causes of a UTI in the elderly, as Lee just led onto, dehydration is one of the main causes of urinary tract infections in the elderly. This is due to many reasons, which I will go into in my next slide. Also, it's women are far more likely to get a urinary tract infection than a man. Everyone know why?
Because we've got a
shorter urethra, and also it's because the urethra is very near other orifices that has a lot of bacteria. Another leading cause in the elderly is constipation and immobility, so not getting to the toilet, and that's also dehydration. So a lot of residents will not drink because they think they won't get to the toilet, which leads to dehydration, but also because they're immobile or can't move, sometimes they don't empty their bladder properly, which can lead on for them getting a residual left in their bladder, which can cause urinary tract infections. So if we look, at our urinary tract system, so we've got 2 kidneys, and everyone should have 2 kidneys. This is the powerhouse where everything happens. So the filtering happens here. So your 2 kidneys produce, the blood goes into the kidneys, it's filtered, and what's left is waste. The waste goes down the ureters and into the bladder. The bladder has 2 functions. It stores urine, and then when you go to the toilet, it expels it out, which is great when it works properly. And then, as we said, the urethra in a woman, it's only 3 to 4 centimeters long. In a man, it's 17 to 30 centimeters long. So it's very different. So if we women get bacteria in the outside of the urethra, it only has a short way to track up, get into the bladder, and cause infection. With a man, which I don't have a picture of the urethra, just imagine, If it tracks up, most of the time it dies before it reaches the bladder. That's why men, young boys, men, do not get urinary tract infections. As they get older, men can, because the prostate lives around here, and because the prostate is here and it can enlarge, then it stops the outflow, and then it's the urine left behind in the bladder that can cause infections. And if we see in this diagram, the bladder is protected behind the pubic bone, and we all have pubic bones, male, female, and if you need to go to the toilet and you pressed on your bladder, so 2 centimeters up from your pubic bone pressed in, you would feel when you need to go to the toilet. So if you have residents that are not emptying their bladder properly, it's very easy to know. If you bring them to the toilet, if they come back, lay them flat on the bed, if you press on their bladder and they go, ooh, that means they haven't emptied their bladder properly. Getting used to this. So if we think of the causes of urinary tract infections, so if we think of the bladder, as I said, the bladder has 2 functions. This is a bladder full of urine, and the bladder should hold about, on average, 500 mils. If you think of your residents, as you get older, the bladder can lose capacity, so about 350 mils for your residents. That is the bladder full of urine, and the urine should be sterile. There should be no bacteria in your urine. And the causes of UTI in the elderly, as I stated earlier, bacteria can track up, get into the bladder, and then multiply. Also, another dehydration. If I said to you, your resident their urine is dark, smelly, and concentrated, what would you think?
Didn't drink enough.
Dehydration or UTI, because they're very similar, and a lot of the time we mistake dehydration for UTI. If you suspect someone has a UTI, push fluids and reassess, because if they have a UTI, they will present with clinical symptoms. Residents that are dehydrated, what's happened is you need your bladder to fill to capacity to have that urine sterilize the whole bladder, and when you go to the toilet it flushes out all the bacteria. If you're not drinking enough, the bladder never fills properly. What happens is the bacteria lays dormant in the bladder and it never gets, I suppose, washed out with all that urine, and it just lives there. Also, and why we don't use urine dipsticks is because when that bacteria gets in to the bladder, it starts multiplying and multiplying. And it's only when it becomes, they multiply enough, they cause clinical symptoms, and that's when you know you have a urinary tract infection. So when you have bacteria in your bladder and you get treated for urinary tract infection, all the antibiotics do is they decrease the bacterial load, but they never get rid of the bacteria fully. And if you have one bacterial infection, the likelihood that will keep coming back, and coming back, till you get rid of the risk factors that cause it in the first place. So in the elderly, that's really difficult. So if you had a resident that had a bacterial infection and they got treated with antibiotics, the antibiotics will get rid of their clinical symptoms, so it might seem they're getting better. If they become unwell again in 2 weeks' time, and you did a urine dipstick, you will find that dipstick is positive, but it doesn't mean it's the cause of their symptoms. It means there's bacteria in their bladder. Does that make sense?
Yes.
So that's why we don't use urine dipsticks, because all they pick up is bacteria in the bladder. So what you need to look at is clinical symptoms. So, as I said, urine is sterile. So if I peed in a pot, what I'm looking for, sorry, I have to improvise because I forgot my, but you don't use that. If I, please don't, when it's in doctor's surgery. So, urine is meant to be sterile. So when you ask someone for MSU, which is a midstream urine, do you know what you're looking for? Midstream.
To do one urine.
Yes.
Thing, then you collect the second one.
Yeah. So what we're looking for is only the urine in the middle of the bladder, because if there was bacteria in there, then you know they have an infection. If what you're looking for really is sterile urine and there's no infection. So midstream urine is, you pee, stop, put the pot underneath, take part of the urine, and then take away the pot and pee again.
Yeah, but that's
And that-
very difficult with dementia people and people that
Exactly, and that's what I'm coming on to. So that's what best practice is in midstream urine. So what you're giving to your GP to send to the lab so a microbiologist can culture it is just the urine in your bladder, because what they want to do is test for the actual bacteria that's causing your symptoms so they can target the antibiotics. If you don't do that and it's contaminated, the microbiologist will report heavy mixed growth, so lots of bacteria, but what's the one that's causing your clinical symptoms? And then they might have to give you a few antibiotics and they don't work. And that's why people always say, I got an antibiotic, it didn't work, I had a UTI, because we don't give a clean sample. And that's why it's really important that the sample you send to the lab is as sterile as possible, which, as we know, is very difficult in the elderly. So the reason we're looking at collecting urine samples and avoiding contamination, the Norfolk and Norwich manage all the urine samples for the county. They get about 700 to 1,000 urine samples every day. These urine samples can vary, and the collection process has not always been standard. And what we found out is that a lot of samples sent to the lab have taken a few hours to get there. And a urine sample is stale after 2 hours. So we should not be using urine samples after 2 hours, because otherwise they can lead to false positives. So by the time you collect the urine sample, it should go straight into the green pot, boric acid, to be sent to the lab. But in reality, we probably see this. So if you, as you say, in a care home are collecting a sample from somebody that has dementia or incontinent, it's really hard to get a clean sample. So if we think those who do go to the toilet themselves, whoops, go back, turn it round. How many are able to give you a sample? Hygiene is also an issue. For them to get it, this is the appropriate pot, so it's wide bore and it's only a collection pot, so you need to collect 10 mils or more for it to be viable. Then we normally dipstick to see if we're going to send it to GP surgery, so we're introducing more contamination. Then it has to get to GP surgery, where it waits around for somebody to collect it. Time is ticking, so how long has it taken to collect the sample to here already? Then when it gets to the GP surgery, someone else might dipstick it. Then it gets into the green pot, which is the boric acid. The most important part of this journey is the time frame of the urine getting into this pot and this pot straight away. And then it gets to the lab. Sometimes that can take up to 7-8 hours. They can sit around. Yeah. So what we need is, this is just a collection pot. It is not for transport. So you should be asking your GP surgery for the yellow and the green. You collect the sample in the yellow pot and transfer it straight away into the green pot, so then it's preserved, and then it doesn't really matter how long more it takes to get to the surgery. So taking a urine sample, so I'll go into the different ways, but what we really want is a urine sample that's not contaminated. Now, you know what best practice is, but in reality is, how do you collect that? So if you have somebody that is unable to give you a urine sample, you might have to use a commode that's clean. That's the best you have, but make sure that they are clean as possible. Make sure that the sample that's taken is not contaminated with other bodily fluids.
then you don't have a middle one.
Pardon?
You don't have an MSU. You have just a normal collection. Because
you have.
in there, it's everything.
Well, there's no point taking it if it's contaminated, really. So you have to get a clean a sample as possible and then wait for a time when you can get one. When you collect your sample in the, when you collect your sample in the yellow pot, what you want to do is make sure that they have clinical symptoms of a urinary tract infection. Then you transfer it straight away into the green. So the green goes on top, it sucks up the urine, and you need 10 mils in that pot for it to be viable to send to the lab, and then it's ready for transport to the GP surgery. This will stop it hanging around and getting stale, but also that you're sending the right sample to the lab in a timely manner. Yeah. So there's different ways to collecting samples, and collecting a sample from a catheter. So I suggest you should not collect a CSU or catheter sample of urine unless you're trained to do it and you're competent. Nurses will probably do it, or visiting nurses will collect it for you, because it's a little more complicated. You have to use the port, it should be clamped, and that you get a clean sample. You should never take a sample from a urinary catheter and dipstick it, because it will always be positive. You have to send a sample to the lab with new clinical symptoms to support why you're sending the sample to the lab. Never ever take it from a bag, because it will be stale and it will be full of bacteria. If you collect a sample like this from the bag and send it to the lab, it will only come back with heavy mixed growth, and they might have to give a broad spectrum antibiotic. It probably won't treat your resident, and then they will just keep getting unwell, or they have to have more antibiotics. So collection packs. Have you all seen the urine collection packs?
Yeah.
Are any of you using these? Yeah? Yes? No? Yeah?
It's the one you gave me.
Yeah.
Didn't quite go where I expected.
Why is that?
Because you decided to have the bowels open at the same time, and it all just
So when you collect a urine sample, what you want is good toileting plans as well, structured toileting plans, and you don't want contamination. So if someone is constipated, fecal soiling, you have to sort all that out before you collect a sample. And anyway, we should have good toileting plans. And as we know, E. coli, which is the bacteria that comes from feces, is the main cause of our urinary tract infections. We should be having good structured toileting plans in the first place, so fecal soiling shouldn't be an issue. But we know some residents are fecally incontinent, and what you have to try and do is get your urine sample around when they have their bowels open. These urine packs are good if the doctor has said, this person has been unwell for ages, we really need a urine sample to decide if we have to continue treating or if they need antibiotics. They're not perfect, but they will eliminate some of your contamination. So your resident should be as clean as possible. So obviously clean with a new pad on, and then put this pad on around the time where you think they're going to have, I suppose, empty their bladder. So after a drink, these pads collect the urine, and then the pad has gel in it, I believe, and then you can split the pad, put the syringe in at around 90-degree angle, and it will suck out the urine for you, and then you put it in the yellow pot. There's lots of companies that make these. We have taken a urine sample, and all the different ways of taking a urine sample. We have quoted Gumpels in there because they do a urine pack. Newcastle Kit is also in there. And not promoting any companies, but they were the ones that delivered to us, and we tested a few to see, because they were, I think, £1.38. Unfortunately, you can't get these on FP10 or from the GP, so if you do want these packs, you have to purchase them yourselves or family members. But it's only when you really need a sample, and because you're not sure what's going on with that person. words again. So, take-home message, do not use urine dipsticking to diagnose UTIs unless under 65, and I don't know if you've got some of your residents are under 65, you can still use a urine dipstick. If it's negative, they probably don't have a UTI. If it's positive, they may have a UTI. It's not full. UTI should be diagnosed with the presence of signs and symptoms, so please use the UTI checklist to support your decision of why you're sending that sample to the GP surgery. So it's also good to say to the GP that if you both use the UTI checklist, that both of you know what you're talking the same language, that they have a high temperature, which is new, or actually they have dementia and they are becoming increased confusion, they had a fall. So it's some of the signs and symptoms of UTI. That's use the UTI checklist, and try and send your samples to the lab in the right container, right time, and that it's transferred over to the boric acid as soon as possible so the urine can be tested and the appropriate antibiotics used. That's it. Any questions, I think?